Yagnik is a professor at the Department of Surgery and and has inspired many budding professionals throughout his career. Dr. Yagnik has done his MBBS and MS degree from and holds a postgraduate diploma in clinical nutrition. Dr. Yagnik is an associate editor-in-chief and clinical and experimental gastroenterologist and academic editor at Surgery Research. Dr. Yagnik is an executive and managing editor for the Global Journal of Medical, Pharmaceutical and Biomedical Update and an active board member of several renowned international journals. He has authored over 190 publications, out of which 104 are listed in PubMed. He has authored a book entitled Fundamentals of Operative Surgery and has written many book chapters and has made significant strides in surgical research. His discoveries, including a novel anatomical pathway for the spread of anal fistula, groundbreaking guidelines on post-operative MRI for anal fistulas, and diagnostic and therapeutic guidelines, have made a huge impact on the community. Dr. Yagnik has received fellowships from prestigious organizations such as American College of Surgeons, the Association of Minimal Access Surgeons of India, the Association of Surgeons of India, the Indian Association of Gastrointestinal Endosurgeons, and the International Society of Choleproctology. He has received numerous accolades for his work, including the Best Researcher Award from the Indian Association of Gastrointestinal Endosurgeons from 2022 to 2023. Dr. Yagnik continues to share his vast knowledge and expertise at state and national level surgical conferences where he serves as a faculty member. We are extremely honored to have you, Dr. Yagnik.
University, UK, and visiting professor at several institutions, including Mahatma Gandhi University in India and Tribhuvan University in Nepal. Trained as a medical sociologist, he has published over 400 papers, contributed to nearly 40 publications on academic publishing, and supervised more than 35 PhD students. Co-editor of academic writing and publishing in 2 decades, and delivered workshops globally on academic writing, grant proposals, plagiarism, and handling rejection in publication. The topic for the first session is the impact of probiotics on reversing gut dysbiosis and improving health outcomes in individuals with type 2 diabetes, a systematic review, which has been reviewed by Mr. Mustansir Kapasi, Mr. Shiansh Shilan, Mr. Hadim Padanwala, and Ms. Priyanshi Gupta. Let's begin the session by welcoming our first speaker, Mr. Mustansir Kapasi. Please join
For the event, each participating team has been given 10 minutes in total, of which 8 minutes are for the presentation. At the end of 6 minutes, a bell will be rung to inform you that 2 minutes are left, after which 2 minutes have been allotted for the discussion and question and answer session, for which the whole team will come out. Thank you. Over to you.
Good evening, everyone. My name is Mustansir Kapasi, and today I'll be presenting on the role of probiotics in managing type 2 diabetes. Here are the agenda for today's presentation. Type 2 diabetes is a global health issue primarily characterized by insulin resistance and increased blood glucose levels. If left unmanaged, it can lead to severe cardiac diseases and neuropathies. Traditional management targets glycemic control through lifestyle changes and medication, but recent research suggests that gut microbiota plays an important role in the development and progression of type 2 diabetes. Probiotics such as Bifidobacterium and Lactobacillus have proven to reverse the gut dysbiosis by maintaining the gut health and reducing inflammation and improving glucose metabolism. The main objective of this review is to make sure about the microbiota changes, the fasting blood glucose levels, and the inflammatory markers in the body. As inflammation in the body body can be tracked by evaluating the levels of inflammatory markers such as CRP, interleukin-6, and TNF. Like cancer and heart diseases, type 2 diabetes is also a major cause for premature deaths, and it results to around 80% of it. Clinical trials demonstrated that gut dysbiosis and gut dysbiosis and type 2 diabetes are linked by glucose metabolism. Additionally, probiotics have been found to promote production of short-chain fatty acids that help in controlling the glucose metabolism and in reducing inflammatory markers. The methodology. This study employed a systematic research of several databases, including PubMed, Cochrane, TRIP, and Google Scholar, and included studies published between 2011 to 2024. And as you can see, the key terms we've used are probiotics, gut dysbiosis, microbiota changes, diabetes mellitus, and fasting blood glucose. Our study, our data extraction mainly focused on microbiota changes, fasting blood glucose levels, and inflammatory markers. We use the Cochrane risk of bias tool, also known as the ROC 2.0, to run the risk of bias. And two of the studies were under high risk of bias and therefore were excluded. Here is a stratified plot of the risk of bias. The inclusion criteria for our study was patients, adults with type 2 diabetes who were using probiotic or symbiotic interventions and were under the age of 8 years, and the follow-up period was more than 4 weeks. And studies that included adults having any other type of diabetes such as gestational diabetes or pre-diabetic conditions or type 1 diabetes, or the people that used prebiotic or non-probiotic interventions were excluded from the study. The Prisma flowchart outlines the study selection process of the 149 records identified. 8 studies were ultimately included, with most of the population coming from Asia. As you can see, China constitutes most of the part of the pie chart, and the remaining Asian countries. The total number of participants were 1095, and the range of median age was between 50 to 60 years of age, and the follow-up period was around 12 to 13 weeks. Speaking of results, 7 out of 8 RCTs in our studies showed a positive shift in the gut microbiota composition. As you can see in this green map over here, that the green indicates an increase in all beneficial bacteria such as Bifidobacterium and Lactobacillus, and 3 studies showed a rise in SCFA levels that help in modulation of inflammation in the body. And you can see that 3 different studies showed a decrease in pathogenic bacteria such as Clostridium, as it is represented by red, that is decrease. 6 RCTs presented a positive shift, that is a reduce in FBG levels. That means that the gut microbiota helped in reducing the baseline fasting blood glucose levels. And here is a plot of all the data that we have accumulated. Here's the mean differences of all the FBG levels, and this has been plotted into. This has been used in the forest plot over here, showing the size effect of the probiotics. A negative mean difference here supports the intervention group, and these values were against placebo controlled. So this is the data of intervention group. The effects of probiotics of inflammatory markers were mixed. 3 studies showed a reduction in inflammatory markers, and 3 studies showed no change in inflammation. That is, it could be possible because of the duration, the dosage, and the patient characteristics. Here is a representation of the findings. Shows 3 negative findings, 3 no changes, and 3 positive changes. That is reduced markers such as CRP, TNF6 and TNF alpha. Here is the heat map showing the trend of the change. In conclusion, the analysis of these 8 randomized controlled trials showed that gut microbiota composition probiotics have been associated with a significant reduction in fasting blood glucose levels, indicating improved glycemic control. An overall decrease in FDG levels in the intervention group was noted across all studies. Though the effect size was variable, long-term effect of probiotics on FDG still needs to be examined. An increase in beneficial gut bacteria like lactobacillus and bifidobacterium was helping in stabilizing the gut microbiota and improving commonly associated symptoms. A decrease in pathogenic bacteria was also observed, such as Clostridium. The effect of admitting markers still remains unclear, and the variability likely could be due to a short follow-up period due to factors like different probiotic strains, dosage, or patient characteristics. These findings suggest that probiotics could be a valuable component of type 2 diabetes management, offering improvements in both microbiota and metabolic parameters. However, further research with standardized protocols is needed to confirm these benefits and optimize probiotic use in clinical practice. I'd like to sincerely thank Mr. RPN, Dr. A.P. Singh, Dr. Sudhir Jha, Dr. Ashish Wane, Dr. Indrajit Banerjee, and Dr. Sushi for giving us this opportunity. And I'd like to thank SSR Medical College for providing resources and environment necessary for the project.
No immediate questions. Can you explain the difference between methodology and methods, please? You talked about methodology. On your slide, you talked about methodology. I don't think you need methodology, I think you need methods. What's the difference?
When we speak of methodology, we are basically including everything including the inclusion, exclusion, and the risk profiles. Guys and methods, we are focusing more on the search strategy. Everything.
Will you call it as a systematic review or as a meta-analysis?
So, a systematic review is a qualitative service of the variable data, as a meta-analysis is trying to follow. While we have some components because of the forest plot, we are not performing a meta-analysis to perform the system.
Any other questions? In which case, I'll put the second question. In your title, you mentioned improving health outcomes as well as reversing gut dysbiosis. You don't actually say anything about health outcomes.
So, health outcomes will not focus on something like mortality or mortality, health outcomes are primarily considered with the parameters that we do, which are the LPG levels.
Thank you.
Our second presenter for this event
will be speaking on the title of the paper, Evaluation of Exercise Rehabilitation Program to Improve Cardiac and Respiratory Health in COVID Patients. But I would like to invite onto the stage Rudraksh Sharma.
forbidden with something. Sorry for the inconvenience. I just wanted to raise your hands if you think that the aftershocks of a global pandemic could be dealt with something as accessible and impactful as exercise. You're right. You are right. So today we'll just focus on how these structured rehabilitation programs will help to improve these following complications which are mainly experienced by the COVID-19 survivors. So these are the contents which we will go through today. And first is introduction, then followed by objective, then the main methodology and results, conclusion, and our references. So COVID-19 has had a significant impact on survivors who are experiencing both cardiac and respiratory complications, such as dyspnea, palpitations, and increased risk of heart failure. In order to address and improve the following complications, some of the studies have shown that exercise-based rehabilitation groups as an intervention plays a vital role in their recovery. So the main objective of the study was to evaluate the effectiveness of these rehabilitation programs to improve cardiac and respiratory functions in COVID-19 patients. So, the methodology and extensive search of literature was done on PubMed database using keywords and Boolean operators. The Boolean operators used were high-intensity interval training, or rehabilitation, or COVID-19, or exercise, and long COVID. And the Prisma guidelines were also followed. The risk of bias was done by using ROB 2.0, and the inclusion criteria was RCTs which were published in English language from the year 2020 to 2024. And also the COVID-19 survivors who were experiencing persistent cardiac and respiratory complications 8-week post-hospitalization. And the exclusion criteria was patients who had any pre-existing complications of cardiac and respiratory health problems. So yeah, this is the Prisma. And in this, as you can see, there are 4 phases. First is identification, followed by screening, eligibility, and inclusion. The total number of records which were finalized, which were identified through database searching was 34,761 at first, after which only 12 articles were found to be eligible after reading full text articles, from which only 6 were included. The quality assessment was done by Cochrane risk of bias tool, in which you can see the red signifies high risk of bias, whereas green signifies low risk of bias, and blue signifies there was no information present. And as you can see, all over the study shows there was low risk of bias, and which further signifies there's a minimal risk of distortion of results and high quality assessment. And this, now I'll talk about the results. In total, 6 RCTs were included, and the total number of participants were 331, with a mean age of 52 years, predominantly females, which was 57.9%. And the rehabilitation group showed notable improvement in VO2 peak, heart rate, left ventricular mass, MVV, that is maximum voluntary ventilation, with improved respiratory endurance, along with increased stability in FEV1 and FVC. And the common measurement parameters used for VO2 peak were bicycle ergometer with the metabolic card, and for the heart rate were continuous ECG. And for ventilatory parameters, it was used spirometry, whereas for the left ventricular ejection fraction, it was echocardiography. And for the left ventricular mass, it was just MRI. VO2 peak. VO2 peak mainly means the amount of oxygen our body can utilize during exercise. And in this graph, the blue signifies for the VO2 peak, increase in the VO2 peak in the rehab group, whereas the yellow signifies the increase in the VO2 peak in the control group. And as you can see, in study 1, 2, and 3, there's a significant increase in the VO2 peak in the rehab group compared to the control group. But in 4 and 5, there is significant increase in the rehab group, but by a small difference. And this VO2 peak mainly signifies increased anaerobic capacity and cardiovascular fitness. So now this graph shows the decrease in the heart rate after 1 minute of rest after exercise, which mainly tells the recovery period. As you can see, in all these studies, there is a significant increase in the heart rate after exercise, which further signifies decrease in palpitations. As I told you earlier, there was palpitations in the symptoms, which was experienced by the COVID-19 survivors. In this, as you can see, HR max is basically the heartbeat per minute a person can achieve during excessive exertion. And in this, as you can see, there is continuous increase in the heart HR max in the rehabilitation group as compared to the control group, with the sub-maximal heart rate remains stable, which further shows better cardiovascular fitness and heart efficiency. And this is a pie chart, and then this, as you can see, total 202 participants were there in the intervention group, and out of 157 showed improvement in this peak. And this pie chart, which shows of palpitations, total 202 participants were there in the intervention group, out of which 130 participants showed reduction in palpitations. So the conclusion of the study was that exercise-based rehabilitation programs have demonstrated a significant improvement in cardiac and respiratory functions in COVID-19 patients. These programs led to a marked reduction in the symptoms like dyspnea, palpitations, and higher incidence of heart failure. And so the limitations were small sample size, and short follow-up duration, and study doesn't address the potential long-term effects of the rehabilitation group. And there was no intervention specificity, as we were focused on high intensity training, moderate intensity training, and low intensity training. And future directions is to work on diverse population and to know the mechanism and some combining therapies or begin comparative effects of interventions and cost effects. These are my and I would like to thank Dr. Banerjee and Dr. Sabane for their continuous guidance, and at the end I'd like to show my gratitude to Dr. AP for giving me this opportunity.
Questions, please.
So the results from each individual study show that there is a statistical significant difference in between the arms, the study arms. Do you think that those results are clinically relevant? The difference is clinical relevant.
As we have done we have put the vector size for the entire for VO2 peak. So basically we got the effective size is 0.78, which is statistically significant. In terms of clinical, we actually mentioned about the limitation that we have small sample size. So currently the total VO2 peak again clinically significant.
She made it perfect. You need to be very careful when you're doing a systematic review. Sometimes the statistics really show that the arm groups are different, but they cannot directly associate with clinical impact. Sometimes the patient can have like 0.1 difference in terms of hemoglobin, but that's not. It's not going to change our patient's outcome problem. So it's a great thinking, so you have that in mind.
by Mr. Nadeem Muhammad Kozilbubus, Mr. Madhav Ramgulam, and Mr. Peran Murga. I would like to call upon the speaker, Mr. Nadeem Muhammad Kozilbubus, for presenting the topic. Please give him a quick round of applause.
Professors and doctors, respected chairperson of school, principal, the faculty members, a very warm welcome to the 4th International Conference on Medical and Health Science. We will do this presentation in intensive fashion.
Springtime children daily lifestyle. So our paper research is from spring to real life. What is the role of springtime in shaping of our child health and development? So ladies and gentlemen, I would like to continue the presentation. So this research paper is done by defining what is child, what is springtime, what is health, and what is development. According to UNICEF, a child means every human being below the age of 18 years and less. Under the law applicable to child, majority is acting early. According to Oxford Dictionary, springtime is any time spent using a device such as computers, television, or game console, or even mobile phones. But according to WHO, springtime is only a time spent passively watching screen-based entertainment on television, computers, mobile phones. What is health? Health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. Again, according to WHO, development is a dynamic process that encompasses physical, cognitive, social, and emotional components. Now, coming to the methods that we use throughout this presentation. First, a thorough literature review was done on PubMed with the following methods: screen time, television, computers, phone, child development, mental health, and together with the Boolean operators. We followed the PRISMA analysis criteria. Here are the inclusion criteria. The OSTI in the article from 2014 to 2024, child is between 0 to 18, impact on cognitive skills, behavior, social interaction, and physical health. The exclusion criteria was duplication, children outside the age of 0 to 18, studies that focus on low or irregular screen time and not exceeding established limits. Here is our PRISMA table. We started with 983 articles. After screening, we got 74 articles. And from the 74 articles, we choose only 4 articles. And for these 4 articles, we assessed the risk of bias through the ROB2 tool. As you can see, the green line represents a low risk of bias. So for our 4 articles, the risk of bias was relatively low in the 5 domain given by ROB2 tool. Now coming on to the results. We took 4 OCTs. 2 OCTs was focused on the mental health status, whereas the other 2 OCTs was focused on the physical development. For the 2 OCTs that was focused on the mental health, there was 181 participants in one OCTs with mean age from 8 to 12 and ratio male to female 1:1. For the second OCT, it was 3,836 and age between 10 to 12. So, for the OCTs, to measure the anxiety, this accelerometer was used. Here is the result. For combined result for the two OCTs, the intervention was to limit screen time only for 3 hours per week. And 97 of the participants in the intervention group was cooperative. Results clearly showed almost a 50% reduce in the total difficulties in the intervention group. The difficulty was internalizing symptoms, externalizing symptoms, peer pressure problems, and emotional symptoms. But what is more astonishing is that the interventional group shows improved and increased in pro-social behavior of 49.7%. Now coming to the 2 studies that focuses on the physical aspect. These 2 studies has total number of 433 participants with mean age of 5.7 and male to female percentage 51% to 49%. These 2 studies measures the BMI and waist circumference in order to know if it leads to relative physical activity or obesity. As you can see here, limiting and monitoring screen TV time has a 60% reduce of BMI, whereas those who have the exposure to TV has only 8% reduced. Here is the waist circumference. Here also, the limiting and monitoring of TV has 0.7% reduced in waist circumference, while those exposed to TV has only 0.3%. So, limiting and monitoring TV has a clear impact of decreasing BMI and waist circumference. To conclude, these findings from this systematic review indicate that reducing screen time positively affects both mental and physical health. However, further research is necessary to confirm the long-term sustainability of these benefits. Addressing this issue would significantly reduce the prevalence of obesity and mental health problems among our young children. So, now I would like to acknowledge a very thank to Dr. Ibrahim Banerjee, Harsha Sabani, Dr. Shusil Dorka, Dr. Sujeda, our research person, and the principal of school, and also special thanks to my teammate, Belen Logan and Manuel Logan. Also, a special thank you to other people that support us throughout this journey, Akira Kutabakas and the task force. Here are my references. I will now invite my 2 teammates to raise on the stage for the question and answer time. Thank you very much.
Any questions from the audience? There's one in the very back. Question of you. The microphone. Before we get to this question, can I raise one question very quickly? In the time of the self-help development, the systematic review feels very much
You see, when we talk about mental health, it also encompasses the development, because the mental health will affect the cognitive behavioral development of the child. If you have a very high level of stress, it automatically your development will decrease, because the level of anxiety will be so much that your behavioral and cognitive will be affected.
As you said that if there is a low evidence for that, if AI is there, then obesity will be less. It will be basically addressing the significant reduce in the obesity, right? So basically, there are so many people who actually stick to the TVs and everything, and they're still lean and everything. Like still lean, and there's no stressor, and they are not obese at all.
If I understanding the question is what in this generation, screen time is omnipresent. How can they do obesity? That's why I was asking you. So this is research to prove that screen time has an impact on the obesity and mental health. That's why this research was carried on to prove that there is significant evidence that screen time lead into obesity and mental health problems. That's why this systematic review was conducted.
There are people who are not actually obese.
Doctor, are you in favor of registering systematic review of any product? Are you in favor of registering systematic review of any product, or are you not in favor?
So we are mentioning, we want to register this.
Yeah, we want to register a systematic review of product or not?
Of course, yes, since we did demonstrate the terrorism bias, we will put that most at least in this case to show that screening time can lead to more complication, not only obesity or stress, but more complication based on also development and also on the well-being of the child.
I'm asking about registration on any portal, like prospective site is registered as systematic review. Are you in favor or not in favor?
I'm in favor.
Reason?
Reason because if this research has demonstrated its utility, it's good to show it to others that we get that based on reduced screen time, the future generation can have a better life.
One systematic review is very important. I was asking if you are in favor for systematic review. This will help we prove medical evidence-based medicine. From this, we can clearly demonstrate that we can use this data in the medical field.
Thank you.
Thank you very much for that.
Next, young investigator team will showcase their findings on the paper titled Clinical Efficacy and Safety of Peptides and versus Monitoring Post-Menopausal Osteoporosis. I would like to invite them, Maheshwara Ramana, Sarvesh Nanku, Murugan Krishnan, and Anusha Chakravanshi. Krishivan would be speaking and presenting their talk. Let's have a round of applause, ladies and gentlemen.
Imagine what would happen if you sneeze and you break it. Now, if you never heard of something like this, you probably say that I'm being unrealistic. Let me tell you, for people suffering from post-menopausal osteoporosis, this is actually the reality. Good evening, ladies and gentlemen. I'm Murugan Krishnan and I'm going to present from this diagram. Let's just start with the WHO statement. So WHO states for postmenopausal women suffering from osteoporosis that 70 fractures occur every minute in both age above 55 years in the world. Postmenopausal osteoporosis remains a significant health concern in society. So here, for the treatment of osteoporosis, we have drugs like bisphosphonates or parathyroid hormones. Now, me, as a medical student, I'm concerned with one particular thing. What is the best line of treatment for my patient? So here, in this systematic review, we are going to compare the efficacy and safety of teriparatide versus alendronate when they have been used to treat osteoporosis post-menopausal women. So we done our research on PubMed and Cochrane database with the body operated and measure being teriparatide and alendronate or osteoporosis post-menopausal. We also applied a figure from August 2017 to May 2024. We included RCTs, English-based text, teriparatide, alendronate, osteoporosis post-menopausal, August 2017 to May 2024. And we excluded irrelevant articles, non-RCTs, cohort studies, other studies, and also other drugs. So here coming to the Prisma. So from PubMed, we actually got 216 results, and from Cochrane, we got 416 results. I made the math for you. This made actually 632 results. So after the de-application process, we had 597 results. We applied our filter and we had 400 results. Now, based on our inclusion and exclusion criteria, we selected 5 RCTs. So to assess the risk of bias, we used the raw-based visualization tool. And to make a weighted bar plot and the traffic light plots, we used ROB2 tool. Coming to the result. So here is an overview of the result I'm going to talk about. So we have the authors and the year it was published. So the first study is going to be by Aquino, H. Aquino, second by A. Ganapati, the third one by S. Ikeda, the fourth by H. Aquino, and the fifth by S. Mori. Now let's go to the weighted bar plots. Basically, as you can see, our bias arising from the randomization process and the bias due to deviation from the intervention were both 100% low risk. The bias due to missing data, missing out of data, was 80%. Bias in measurement of outcome and bias in selection of reported results were 40%. On overall, we had a bias of 60%. Coming to the traffic light plots. For our first study, we showed some concern for the risk of bias. The second one was high, and the last week shows low concerns. Now, let's go to the first study. So, it was a sample size of 559, with women age, with a mean age being 81 years. So here, on this graph, the blue part represents at 72 weeks, and the green part represents at 120 weeks. Basically, in this study, there was two groups. The teriparatide alendronate group and the alendronate group. So this number you're seeing there is the population which achieved bone mineral density greater or equal to minus 2.5 standard deviation. So we can clearly see for the bone mineral density of the spine that alendronate, the result of alendronate was better than the teriparatide alendronate group. However, to that the teriparatide alendronate group was far more superior. A limitation in this study was that women with both low risk and high risk of fracture were actually included. Coming to the second study, so the sample size was 86, with the mean age of women being 54 to 70 years old. So here, again, there were two groups. The first group was 2-year daily teriparatide, and the other group was 4-year cyclic teriparatide. So concerning the spine strength, for the spine strength, there has been an increase in both the even though for the 2-year daily, it was slightly more. For the hip strength, it basically there were no significant differences. Again, here we had a small sample size application, and here CT scan was used to evaluate both high and low velocity and mineralization. Coming to the third one, there was a sample size of 96 with women aged at least 65 years old. So here we have a graph depicting the quality of life. The quality of life was much better in the teriparatide group compared to the alendronate group. It is also important to note that the use of weak teriparatide demonstrated inhibition in vertebral collapse, increase in bone mineral density, and bone union was promoted. Again here, limitation was small sample size. So coming to the fourth study, here we are talking about morphometric vertebral fractures. Again, the two groups, alendronate and teriparatide. So there was a sample size of 324 with women aged at least 75 years old. the rate of morphometric vertebral fracture was more in the alendronate group compared to the tripartite group. So it is also important to note that in both groups there was some mild to moderate adverse effect. So potential limitation here was also sample size. Now coming to the fifth study, again comparing morphometric vertebral fracture, the result was like the previous one. There were more morphometric vertebral fracture in the alendronate group compared to the teriparatide. It is also very important to note here that in the group which used alendronate, there were adverse effects like infections, GI disorders, musculoskeletal and connective tissue disorders. And here, another limitation, so the sample size was small. So here is a graphical representation of the fourth and fifth study. So, as you can see, from 2021 to 2023, in both the group, alendronate and teriparatide, there has been a decrease in morphometric vertebral fracture. However, if you do the math, you will see that in the teriparatide group, that decrease in morphometric vertebral fracture was more significant. Now, let's conclude. Basically, the bone mineral density in femoral neck, alendronate proved to be superior than teriparatide. More adverse effect than alendronate showed more adverse effect than teriparatide. Now, if we look at the bone mineral density for L2, L4 vertebra, hip, for promotion of bone union, improvement of pain, incidence of morphometric vertebral bone fracture, and quality of life, teriparatide proved to be far more superior. Hence, we concluded that teriparatide is more efficient and safer than alendronate. So, just a side note here, my team and I intend to conduct future research between alendronate and teriparatide within the Mauritian population. So, I want to thank Dr. Indrajit Banerjee, Dr. Harshad Salani, Dr. Jha, and Dr. Sushil for all these weekly seminars, and also I want to thank Dr. Ebise. So, these are my references. Thank you very much for your kind attention. I will now allow my team members.
Okay, thank you very much. Any questions from the audience? My first question is, you're looking for two drugs. These are generic names. Should you also look for brand names?
I'm sorry, can you please repeat the question?
You're using for two drugs. Yes. These are generic names.
Yeah.
Should you also use brand names to look for this? An American study might use the brand name for the drug rather than the drug name or the name.
The thing is that the brand name can change, but the one which I've used is the exact name where in every part of the drug you're going to find it. So that's the reason maybe we use. That's the reason actually we use teriparatide and.
So based on our research, what we can do other way to people itself, because basically as
Shivani, Mr. Ruparjan Rishabh, and Mr. Saeed Amar Ali. I would now like to call upon Ms. Amita Trivedi to present her title. Please give her a warm welcome. Good afternoon, everyone. My dear judges, faculty members, and my dear colleagues. I, Amita, on behalf of my team members, Taresh, Kamal, and Rishabh, will be presenting on the topic the emerging role of transcranial imaging stimulation. I will be briefly talking about the introduction, objectives, methodology, results, and conclusion of our paper. I would like to start by asking you all a question. Have you ever experienced a moment in your life when you couldn't recall something important, a word, an event, or worse, someone's name? What if that becomes the norm due to Alzheimer's disease? We live in a world where memories define us, and Alzheimer's disease is slowly unraveling that thread. So today I invite you all with us in exploring whether transcranial magnetic stimulation could be the key to preserving these vital fragments of our life. First described by Dr. Alois Alzheimer's in 1906, it has ever since become the most common cause of dementia. It has been extensively researched, which has rendered a few neuropathological abnormalities infamous, like the deposition of beta amyloid and tau proteins in the neural framework of the insightful brain. The insightful brain is a collection of distributed regions of the brain that are interconnected and are responsible for memory and cognition, which include the parietal cortex, the hippocampal network, and the precuneus. For long, the treatment of Alzheimer's disease has hovered over symptomatic relief, and not a lot of consideration was given to individual variability in the progression of the disease. Only recently has there been evidences that show that there are treatments that will slow the progression of Alzheimer's disease, and one such novel therapy that we repetitive transcranial magnetic stimulation. It is a non-invasive form of brain stimulation that gives us an opportunity to modulate the intrinsic neuronal networks of our brain. The objective of this paper is to prove the efficacy of repetitive transcranial magnetic stimulation as an adjunct to pharmacological therapy. For the literature search, an extensive review was done on PubMed using a combination of mesh terms like precuneus or hippocampus and transcranial magnetic stimulation and Alzheimer's disease. This systematic review was done in accordance to PRISMA guidelines. Our initial search yielded 64 papers, and we considered papers from the last 5 years and were left with a total number of 51 papers. We limited our study design to randomized controlled trials and got a total of 11 papers. These 11 papers were individually analyzed by our team members, and we selected 6 relevant papers for our systematic review. All the randomized controlled clinical trials completed and available between January 1st, 2019 and June 30th, 2024 were screened thoroughly and included in our systematic review. All the non-randomized clinical trials, cohort studies, case control studies, cross-sectional studies, editorials, case series were excluded from our systematic review. We also assessed the quality of our overall risk indicates a high quality study with minimal bias, whereas a high overall risk indicates a less reliable study with significant, low overall risk indicates studies with a high quality of results, whereas a high overall risk indicates studies which are less reliable. And unclear risk indicates studies that have uncertain qualities either due to lack of information or lack of information. The 6 RCTs that were considered for our paper included patients who had an established diagnosis to 85 years of age with a baseline clinical dementia rating score of 0.5 to 1, a mini mental state
examination score of 80 to 26, CSF evidence, CSF biomarker evidence, and patients who are already on treatment with a pharmacological agent for at least 6 months. All these 6 RCTs showed favorable results for RTMS as an adjunct therapy. Among the most striking results was one shown by Young et al., which showed a mean change in the ADAS-COG score from 30.7 to 27.3 in the RTMS group and from 31.7 to 33.3 in the sham group. Another result on the ADAS-COG scale was also shown by Cog et al., which showed a mean increase in 0.67 in the RTMS, a mean decrease of 0.67 in the RTMS group, and a mean increase of 1.4 in the sham group. Another study based on MMSE scores gave us the result that showed a change from 15.71 to 17.17 in the RTMS group and from 15.69 to 16.18 in the sham group. ADAS-COG, CGRSB, MMSE, these are all clinical scales that are used to evaluate and quantify the changes we see in cognitive function in patients of Alzheimer's disease in response to treatment. After reviewing the results of these 6 papers, a change on these scales were evaluated and put together after an interval of 2 to 24 weeks of RTMS therapy. As you can see from this graph, the ADAS-COG scores are very different trajectories in the RTMS group and in the sham group. The RTMS group is shown by the black line, whereas the sham group is shown by the yellow line. In the RTMS group, we can see that there is improvement in the cognitive function because there is increase on the ADAS-COG scale by an average of 2.75, whereas on the sham group, we can see that there is deterioration of the cognitive function because there is increase on the ADAS-COG by an average of 2.5 points. The CDR-SB score also shows us the same results. The sham group, which is shown in yellow line, and the RTMS group, which is shown in black line. The sham group shows increase on the scale by an average of 0.096 points, and the RTMS group shows a very mild increase by 0.075 points, which indicates that the RTMS group can maintain the cognitive function. In conclusion, transcranial magnetic stimulation shows significant potential as an effective treatment for Alzheimer's disease. Along with its non-invasive nature and its ability to modulate intrinsic networks, it can also slow the progression of the disease. While research is necessary to optimize its application, we believe that transcranial magnetic stimulation serves as new hope before the silent pandemic hits mankind. And on that note, I would like to conclude my presentation. These are my references. Thank you so much.
Any questions? Yes, no. Let me ask the first question while our colleagues come on board. Since this is an adjunct to pharmacological interventions, that's a confounding factor. So how do you know that this intervention works, or whether it is an intervention that works only with a particular kind of drug, or works better with a particular kind of drug as the adjunct to pharmacological intervention?
So basically, all the studies that we have included here, the patients that were included in the studies are already being given pharmacological
Potentially different therapies in different countries, different doses, so there's a confounding factor for your intervention.
So you stated that we tested the efficacy. Did you test efficacy or effectiveness? This is the first question. And what's the difference between efficacy and effectiveness?
without the person knowing that he or she is receiving TMF. That brings attention to your risk of bad
Assessment, specific domain number 2, concealment and blinding and concealment of patients.
It's very interesting.
Mention is proper. Do you think the objective you mentioned is proper? And what is the difference between aim and objective? What is the problem with the objective you mentioned? No, not all. What objective? Objective should follow smart criteria. Should be specific, should be measurable, achievable, relevant, and time bound. Do you think that follow all the things?
Now I'd like to invite Dr. Sushi to facilitate our children's research. Dr. Vibhuti, let's have a round of applause, ladies and gentlemen. Dr. Vibhuti. As our first day of the fourth international conference comes to a closure, we would like to thank all our esteemed guests, researchers, and colleagues for sharing their vast wealth of knowledge with us along with their precious time.
The unprecedented site exchange here today will undoubtedly